Okay. Hi, everyone. Welcome to this week's staff round. I'll go slowly just so that people are still logging in, but it's a couple of minutes past. So we've got two excellent talks coming up today. I'd like to introduce the first one, which Amelia Swietlik is presenting on behalf of Dr. Mikulash. And this is a project in the genetics of pulmonary arterial hypertension, which has arisen from one of the NIHR rare diseases programs, and which has been a terrific set of projects largely focused around this campus. So Amelia, I'm really looking forward to hearing what you've got to say about this. Thank you.
Thank you. Sorry, the presentation is loading, so I'll give me a second to look at it. Can you hear me well, and can you see my slides?
We can both hear and see you, so yep, all is good.
Perfect. Thank you. So thank you for the opportunity to present today. And as you mentioned, the title of my presentation is Genetic Landscape of Pulmonary Arterial Hypertension, and the scope of this presentation is twofold. First of all, I would like to give you an overview of genetic architecture of PAH, and secondly, would like to show you the methods we use to discover new genes and how these methods are transferable to other rare diseases projects. So pulmonary arterial hypertension is a rare disease that is characterized by constriction and obliteration of small pulmonary artery vessels, and this in consequence leads to right ventricular failure and death. PH is classified into 5 groups according to driving pathophysiological mechanism, response to treatment, and hemodynamic features. The accurate diagnosis of this condition became possible in 1950s with the advent of right heart catheterization. And since then, there have been multiple changes to both definition and classification. So the initial definition took under consideration mean pulmonary artery pressure, and the cutoff value was established at 25 millimeters of mercury. Recent data showed that this cutoff should actually be slightly lower at 20 millimeters of mercury, as the studies show that in normal conditions, under normal circumstances, mean pulmonary artery pressure is around 14 millimeters of mercury, which plus minus 3 millimeters of mercury, which gives us the upper limit of normal at the level of 20. And since the advent of right heart catheterization and our research in pulmonary arterial hypertension, there have been multiple changes to the classification, and these were mainly driven by better understanding of disease pathophysiology, with the discovery happening around year 2000 when we discovered causative role of bone morphogenic protein in pathogenesis of PAH. And this influenced the way we classified the disease as hereditary and non-hereditary, and also how we approach patients. So particularly in the recent guidelines, there is the recent guidelines highlighted the importance of genetic testing. So with this in mind, we the UK investigators set out to elucidate genetic underpinnings of PH in UK cohorts. So up until recently, little genetic testing has been happening within the NHS for those patients, despite guidelines that were insisting or encouraging us very much to do such testing. So the large-scale testing in UK was mostly up until recently done within the research setting, and this was through the NIHR Bioresource Rare Diseases study. So now I would like to show you one of our participants, 71-year-old gentleman of European descent, diagnosed with idiopathic pulmonary arterial hypertension. He presented in WHO class 2 with preserved 6-minute walk distance, although he significantly desaturated on exertion. He had severely deranged hemodynamics, but normal lung volumes, typically for patients with PAH, very low KCO. He didn't have any family history at the time of PAH, at the time of inclusion to the study, but had multiple comorbidities typical for his age. And his demographics are very important because in countries with aging population, PAH is now frequently diagnosed in patients, in elderly patients, and they respond, we know from the recent registry data that they respond to treatment less well, they have worse prognosis, and there are a series of characteristics that are very different to those that we have seen 30 or 40 years ago, when PAH was mostly affecting young females who are often obese. So to address this issue within a research setting, we devised a research study which concepts can be broken into 4 stages. The first stage is forward phenotyping, which is a process of describing phenotypes for case control analysis. And this forward phenotyping approach can be again broken down into three stages: clinical diagnostic workup, clinical phenotyping, and computational phenotyping. Once we have our phenotypes defined, we can move to the process called forward genetics, which is a molecular genetic approach used to elucidate genetic underpinnings of the given phenotype. Once we have our candidate genes, we can reverse this process, which is now called reverse genetics, and through experimental approach find how given mutation is affecting the phenotype. And finally, once candidate genes, function of candidate genes is in keeping with the phenotype, we can deepen our understanding of the role of these genes and run further studies by looking into reverse phenotyping. And this again can be broken down into a couple of stages or use multiple resources. One of these resources is recalled by genotype studies. So this is the research schema for genetic discovery. On the clinical side, which has been run side by side research project, we discussed this patient in multidisciplinary meeting and validate genes according to American College of Medical Genetics and Genomics. Additionally, there are other initiatives such as CleanGen and CleanVar, which help us to curate genotype-phenotype associations and validate them. So since the landmark discovery of BMPR2 mutations in PAH in year 2000, we discovered over 20 other genes, which in total account for around 25% of cases with idiopathic or sporadic form of the disease. So the remainder does not have genetic diagnosis. The fraction of patients without genetic diagnosis is quite high, and it's related to 2 phenomena. One is called genetic heterogeneity, which is the situation in which sequence variation in 2 or more genes is responsible for the same or results in the same phenotype. And you can see it depicted on figure A, where, for example, sickle cell disease is associated only with 1 gene, but phenotypes such as intellectual disability is associated with over 800 genes. Pulmonary hypertension sits probably somewhere in between, with 20 genes so far discovered, and probably many more to be found. The second phenomenon that makes the genetic discovery difficult is phenotypic heterogeneity. We know that our current classification is not ideal, and not all the patients sit neatly into or fit neatly into single category, and there is also a lot of heterogeneity within the groups and subgroups. So, for example, patients with mutations G2, ALK1, or endoglin may present with PAH, but can also present with vascular anomaly syndrome such as HHT. Early patients with mutations in TBX4 can present with IPAH with or without small patella syndrome. So the rare PAH can be categorized according to pathways affected or gene functions. And the most important pathway in PAH is TGF-beta pathway, in which 9 genes has been linked to the disease. And even its central role in PAH, it's not surprising that multiple therapies are trying to either enhance or rescue this pathway. Another big group are transcription factors, with TBX4 and SOX17 being responsible for a significant fraction of cases, especially in pediatric population or young adults. The third group are channelopathies, represented by 4 or at least 4 genes, and there are a number of new genes discovered over the last 2 years through international collaboration. Similarly, common polymorphism have been associated with both differential response to treatment and differential disease penetrance. The biggest so far GWAS in PAH covered two loci, one enhancer near SOX17, which is also our rare causal gene, and another locus in HLA. So the proportion of unexplained cases varies from study to study. In study by Graf, published in 2018, which is a study from NIHR Bioresource, around 24% of cases with sporadic disease have been had a causal genetic cause identified. In Zhu et al. Published in a year later, on a similar cohort from States, 14% of cases have been explained, but the composition of the cohort was different. These patients were unselected group 1. And the largest proportion of explained cases was shown by one in this Chinese cohort, whose characteristics were very different from those of European cohorts. 39% were explained. So we can again break down the causes or factors contributing to missing heritability into at least 4 categories: unknown sequence variation, interactions between genes and environment, population-dependent heterogeneity, and epigenetic inheritance. And for the remainder of this talk, I will focus on rare and ultra-rare variation contributing to missing heritability in PAH. So our study pipeline consisted of internal and external data sets. These data sets were harmonized, data was verified, and we also assessed the data set for missingness. All the data was annotated with human ontology terms, and in cases where those terms were not available, we developed terms to better describe patients. We then performed forward phenotyping, which consisted of 3 before mentioned stages: diagnosis, clinical phenotyping, and computational phenotyping. And in parallel, whole genome sequencing data were filtered, and explained cases were appropriately annotated. We then used those phenotypes for case control analysis. Importantly, because of the high missingness in a clinical data set, we performed the analysis on both complete and imputed data. As I mentioned before, we performed forward phenotyping in 3 stages. So we annotated all the patients with their diagnostic group and subgroup labels. We then used clinical phenotyping, which was mostly based on extreme phenotype approach. So we divided patients into age strata, which is particularly important for our patient who ended up in the highest age strata, and by KCO strata. Low KCO is a typical feature of patients in patients with pulmonary vascular diseases and characteristic feature of PAH, although the distribution or the degree of change is variable. And lastly, we performed computational phenotyping based on human phenotype ontology, and we used 3 different machine learning methods to devise those phenotypes. To validate the concept of ontological similarity for a rare variant association study, we calculated strength of ontological similarity in clusters that are already defined, such as patients with hereditary hemorrhagic telangiectasia, and they proved to be very similar to each other. And similarly, in clusters defined by mutation carriers. And here the response was variable. We found a couple of clusters driven by or described by BMPR2, EIF2AK4, and KDR and ALK1 status, which were similar. The other clusters were not characterized by high similarity. All our 3 machine learning methods yield some interesting results. So these are the results from partitioning around Meadows algorithm, which produced 4 clusters, 4 of which were statistically significant. These clusters are different in respect to percentage of cases with mutations, which is quite important because if we choose the cluster, in this case cluster 2, which has a low proportion of explained cases, we may end up with an enriched population, which will allow us actually to discover the genetic architecture of the unprivileged group. Interestingly, this cluster 2, phenotypically overlapped with 2 clusters devised on clinical basis, namely high age group, higher age and low KCO, showing the convergence between clinical and computational phenotyping. And similarly to partitioning around Meadows, affinity propagation clustering identified clusters that were driven by features that are already of interest in clinical phenotyping, such as strong autoimmunity signal, congenital heart disease, age of onset, but also by some other features like substance abuse. So again, there is some overlap in clinical and computational phenotyping, but computational phenotyping has an advantage of producing more clusters, and also clusters that have not been investigated previously. And the third algorithm we used was called divisive hierarchical clustering, and it also produced phenogroups that were characterized by different diagnosis, functional status, and outcomes. So we took all these clusters together and performed and selected them based on a couple of features. Mostly the computational phenotypes, we wanted the groups to be representative in terms of numbers. We didn't want them to be too small. Obviously, we wanted all the patients within the groups to have whole genome sequencing. This is probably the most important slide I'm going to show you today. This slide shows the genotype-phenotype associations that were revealed by our rare variant association study. And on the x-axis, you can see clinical phenotypes. So both diagnostic and those produced by clinical phenotyping. And on the y-axis, you can see posterior probability of association. And if you remember the previous slides and the genes that were shown before, we managed to replicate almost all previously reported risk genes. And additionally, we found 2 new associations, namely association between patients with PAH and KCO in lower tertile, and PAH and old age. So only protein truncating variants were found to be associated with these two clinical phenotypes. When we grouped patients by mutation status, there were significant differences in age and KCO between BMPR2 mutation carriers and KDR mutation carriers. But when you look at patients carrying EIF2AK4 mutations typical for PVOD PCH, these patients were similar in terms of degree to which KCO was reduced, but very different in terms of age of onset, with KDR mutation carriers being much older at the time of diagnosis. Using computational phenotypes, we corroborated the previous association, which was the association between protein truncating variants in KDR and complex phenotype PAM2, which was characterized by low KCO and older age of onset. But we also picked up 4 new genes, among which the most promising is alpha-5 subunit of collagen 6, but also others that seems very plausible from functional perspective. So human KDR gene encodes VEGFR2 receptor, and VEGF is one of the most important branchogenic factors responsible for cell survival, permeability, migration, and proliferation. And disruption of VEGF signaling has an established role in PH. Inhibition of VEG signaling by Sugen combined with chronic hypoxia was shown to trigger severe antiproliferative PH in rats. And we also know there are literature reports about patients developing PH while being treated with bevacizumab, dasatinib, or bosutinib, which all block VEGF signaling pathway. So in our study, we discovered four such patients with KDR mutations. We started collaboration with US Biobank, who had similar cohort, and discovered four more protein truncating variants with similar characteristics. We also found patients with missense variants, but these patients did not show, or these variants did not show association with the disease, and particularly no association with the phenotype that protein truncating variants were associated with. And in this table, you can see what are the characteristics of protein truncating variant mutation carriers. They are older. They have significantly reduced KCO. They have quite high percentage of patients with some pulmonary fibrosis, and 50% of these patients also had systemic hypertension. This was not statistically significant, but quite relevant when we look at the side effects of tyrosine kinase inhibitors. And pretty much similar characteristics were seen in US cohort. When we looked at CT scans, all 4 patients harboring protein truncating variants showed some parenchymal changes, which at least in 3 cases could have been responsible for severely decreased KCO. And following of death of our index case that I showed you at the beginning, his daughter developed PAH at the age of 53. So there was no family history when the patient was included into the study, but his daughter developed the disease further down the line. She was diagnosed with severe form of pulmonary hypertension, showed severely reduced KCO at 40% predicted. Her CT scan again showed some parenchymal changes, and wedge biopsy that was performed several years prior to the diagnosis also showed fibrosis. Both father and daughter were Sanger sequenced and shown to have to share the same KDR mutation. Our finding was then corroborated by others through the through animal studies, and also by showing familiar segregation into French families. because our study was, because the genetic diagnosis in UK was mostly driven by research project, we were very interested about the attitudes and barriers towards genetic testing in NHS setting. And upon looking through the literature, we found out that, for example, in the United States, almost or over 80% of clinicians do not refer or only rarely refer patients for genetic testing. This is mainly because of the insurance issues. But the most important driver for genetic testing in that setting was patient inquiry. Totally different situation is in Europe, where genetic testing, or where NHS, when the healthcare is nationally funded. And for example, in France, genetic testing is offered to all patients with pulmonary arterial hypertension, PVOD, and PCH, and also to their immediate family members who might be at risk. The publication describing the situation in UK is now being is now in process, but the results of the survey show that there is a huge variability in UK, and the genetic testing is basically at the discretion of attending PH physician. So to quickly conclude, missing heritability in PAH remains a problem and should be tackled mainly from the phenotyping perspective, making the phenotypes easily exchangeable. One of the ways of doing it is through annotating patients' characteristics with human phenotype ontology terms. As I show you, by doing so, we were able to produce distinct computational phenotypes. These computational phenotypes partially overlapped with clinical phenotypes, and at the same time were much easier to devise and much faster, and did not require domain knowledge. And using complex computationally derived phenotypes, we corroborated previously discovered genes and discovered some new genes. In the future, we should all work on an open standard for sharing disease phenotypes, and this should be developed within the regulatory framework that will allow integrating research and clinical practice into common pipeline. And with this, I would like to thank all the patients and their families, our collaborators across UK, my supervisors, Nick Morell and Stefan Graf, Peter Robinson from Jackson's laboratory for work on HPO ontology, and my colleagues from bioinformatics team. Thank you.
Amelia, thank you very much. And we can certainly underline a desire for a forward-thinking and innovative regulatory environment, which I'm sure won't happen anytime soon. But so thanks for that presentation. We've got very little time for questions. I'd like to ask a couple, if I can, while I'm waiting for people to type things into the chat. One is, if we put to one side genetic counselling, how many patients, or do patients actually have their management changed by genetic results? Their direct clinical management.
So not at the moment, and this was one of the reasons why in UK there was no much drive for genetic testing, as having genetic diagnosis was not impacting up until now what we can do for these patients. But I think the situation will quickly change, and there are some druggable genetic pathways that we are going to explore in the very nearest future. So there will be increasing interest because it will impact patient management.
Yeah, I'm sure it will in the future. Thank you. A question from James Nathan. Is KDR expression limited to the pulmonary endothelium, or is the phenotype thought to be related to VEGF resistance?
So the fact that the VEGFR is ubiquitously expressed in endothelium. What we've seen when we use tyrosine kinase inhibitors, there is a very robust phenotype that is outside pulmonary vasculature. But when we look at conditional knockouts, these changes are mostly related to pulmonary vasculature. So tackling KDR pathway will be very, very tricky.
Thanks. And final, very quick question. What proportion of UK pulmonary hypertension patients are in your cohort, and what scope do you have to expand that nationally, or will you have to go internationally if you want to increase numbers?
So the initial idea was to include every patient that is diagnosed within UK. Our cohort contains UK patients, but also some European cohorts to lesser degree. So the initial idea was to include everyone. We did not manage because not all patients are willing.
So what proportion do you think?
But I think it's probably around 90%.
Okay, so you'll have to go internationally to get your numbers up any further. Amelia, thank you very much for your presentation. It's terrific. Gareth, can I ask you to materialize?
Hi, I'm materialized.
Thank you. So over to you.
Thank you very much. I'll just click the right thing here. Okay, that should be all up and working now. Is that okay, Ken? Have we got the brilliant? Okay, super. Yep. Well, I got the opportunity to present this to the Grand Round, which is really exciting because technology in healthcare in the sort of actual clinical front end setting is advancing rapidly, and the tools and things that are being given to us to use in patient care, I think, are getting more and more exciting. And I thought I'd take the opportunity to let you know what's going on in endoscopy. And I'm sure that within your own specialties, some of the things I talk about, you'll immediately see are coming and are going to be there to help. So I'm going to talk a little bit about a device, something called biodegradable materials for stenting, and then I'm going to talk about artificial intelligence and its use in endoscopy during the talk here. So I thought I'd just start with a case presentation. It's actually pretty run-of-the-mill, this, but for the fact we got to use some of the new technology on this case. So a 58-year-old female presented to the hospital on the 13th of June with right upper quadrant and epigastric abdominal pain, with dark urine and pale stool, with normal Usinase and abnormal liver function tests and a very raised amylase. So she went on to have a CT scan, which essentially shows gallstones in the gallbladder, evidence of cholangitis with a thick-walled bile duct, and I've just drawn an arrow that's about a centimetre away from a little fleck of calcium, which was the stone in the bile duct, which I don't know if my mouse is there, but it's sort of circling that there. So therefore she was referred for an ERCP, and what happened during the ERCP was that the guide wire went into the pancreatic duct, which causes those of us that do this procedure to panic that we might cause post-ERCP pancreatitis, which is the biggest fear we have when we do these procedures, because it can hospitalize patients for weeks or months. And so what we do normally is place a small plastic stent into the pancreatic duct, but that means that the patient has to come back and have it pulled out again. So we've now got access to these biodegradable stents. So I placed one of those for the patient, and that dissolves over about 9 days. We then went on and did the rest of the procedure and accessed the common bile duct and removed the small stone with the balloon. And then I just commented that her right hepatic duct inserted in a funny place, which is just important for the surgeons to know if they're going to operate. And then this is the picture of the ERCP, and if you look very closely at where the actual tip of the scope is, there's a very faint grey image of this sort of helical stent, which is how the biodegradable stents are shaped. And so the patient got better and went home the next day, as they do, and then might have an outpatient cholecystectomy. So that's sort of just to say that we've got new technology that we're using on run-of-the-mill cases, which I think is good news. Very briefly, an ERCP is a procedure that, because I want to talk about the pancreatic stents, but I thought I'd better just go back to a little bit of basics on endoscopy. So an ERCP is an endoscopic retrograde cholangiopancreatography procedure that allows you to place a guide wire into the bile duct where it opens up in the duodenum, use X-ray to highlight the biliary tree, and then pull out stones or stent strictures or whatever it is you need to do. So we do it for CBD stones, strictures in the bile duct caused by malignant or benign disease. We might use it to deal with pancreatic duct stones, and then assessment of PSC. And patients, they can bleed, they can perforate, they can get cholangitis, but 1 in 20 will get pancreatitis from an ERCP, and of those, 1 in 200 will die. 1 in 20 of the 1 in 20 will die, basically. So it's quite a significant sort of risk. And pancreatitis is obviously a massive inflammatory condition where a bomb goes off in the abdomen, and the patients can have both short and long-term consequences. So I'm just highlighting this because it's our big panic that we have. So and so, you know, anything we can do to prevent it from happening, particularly when our younger female patients are most affected and are most at risk, we do. So we've got a few things that have come up in the literature recently. So if you take less time to go into the CBD, and you carefully observe your trainees, be more aware of the risk, give NSAIDs or fluids before the procedures, and put a stent in if you put a wire accidentally in, then you know, that can all help. And like I said, at the moment, we've only had these sort of plastic stents to put in, which we have to do a whole other endoscopic procedure to get the patient in. And what's been created, essentially, these are made of a complex starch that just dissolves inside the body. And rather than your traditional plastic stent that drains down the middle, what this has to do is it has to maintain some sort of drainage shape. So they've made the stents in a helical pattern, which maintains the helix as it dissolves. And so the drainage actually goes down the helix, a bit like a helter-skelter, while it's in situ, and it doesn't lose that helical shape during the dissolution phase of the stent. But once it's out and gone, it's gone. We can also use these, as well as using them in the pancreatic duct, we can also use them in the common bile duct for patients that have had a bile leak that after a surgery that just need their biliary tree decompressing. And again, they don't have to come back to have the stent removed. It dissolves over a longer time than 9 days, but does the same job. And what they've done is they've essentially manufactured these biodegradable stents in various periods of dissolving. So there's what they call a slow degrade, medium degrade, and fast degrade stent. So a fast degrade dissolves in 9 days, a medium length in 30 days, and a slow degrade in 45 days. And so depending on the indication that you've got, it will determine which one you pick. But actually, in reality, the only 2 indications really for these are prevention of post-ERCP pancreatitis and bile leaks. So we've started stocking 1 stent for each of those. But I mean, biodegradable material, it must be able to have other uses for repeatable, removable devices. I mean, in other benign disease in the GI tract where you think you want to put a stent in, nickel titanium alloy stents that we use, they get embedded into tissues, they cause granulation, inflammatory reactions, and all sorts of other problems for patients. But if you can put in something that can hold open any luminal structure and then just dissolves after a period of time when it's for when it's not needed, that's a big win technologically. I thought I'd just show, not this one, a video of it going in, which is at 2 minutes and 29 seconds. Here we go. So this is, I'm just going to press play here. So this is just a video of what we do. And that's the stent being pushed into the bile duct with some X-ray screening guidance running alongside. So we just push it along a guide wire into the pancreas duct and go. And then I just thought it's nice to see what the stent looks like on, on the inside for real. Okay, good. Excellent. We don't need to sit on. So that's the biodegradable sort of stent stuff that we're using. I would say they are quite painfully expensive. Each stent costs about £450. So that, but for the health system, the cost of doing a repeat endoscopy is is about 600 or 700, and the patients at the moment all have to isolate at home for 3 days before they come in. So there's also a personal cost for the patients that can be reduced. So I'm just going to move on to talk about how slightly more high-end tech, if you like, is IT tech is coming into endoscopy, and talk about artificial intelligence, which if anybody's got any interest in it, you'll have seen this basically exponential drive in peer-reviewed AI publications across all sectors over a 20-year period. And I have no doubt if we look at 2020, 2021, these will have almost certainly grown in the same way. It's certainly coming in radiology and histopathology from what I've read, and it's here for real in endoscopy and gastroenterology. So the sorts of applications that we've got already are in lesion detection, lesion type differentiation, which I'm not going to talk about here because it's a bit specialist, capsule endoscopy, and on reporting. So I was going to start with how AI is in on reporting. So essentially, this is using an artificial intelligence natural language processing algorithm to be able to improve quality. And NLP is basically a system that allows you to go into a non-database environment and be able to pull out information that you need. So whereas a lot of reporting that we do for endoscopy is done on tick boxes. So then, provided people have ticked the boxes, I can go, how many polyps did we find in March, whatever, and then the endoscopy database will count the number of boxes that were ticked across the number of patients done, and it will spit a number back at me. But of course, if a user decides not to use those tick boxes and just type it in free text at the end of their report, then the strength of the database is lost. And of course, with a system like we've got here, like Epic, where lots of people are typing in lots of notes all the time and not necessarily using the problem list, for example, or the real database elements that allow people to extract high quality information, natural language processing allows you to interrogate and look at that. So a project that was done was looking at a clinician who wasn't doing as well with their polyp detection rate when they did colonoscopy, and that was clinician E. And so what they did was they used a natural language processing algorithm in an endoscopy reporting system to ask it to differentiate whether polyps were on the left or the right of the colon, and whether they were adenomas or serrated lesions. And essentially, by analysing 5 different clinicians, where clinicians A, B, C, and D were performing better in terms of polyp numbers compared to clinician E, they were able to have the NLP spit back and demonstrate that clinician E was not seeing as many right-sided, small-size adenomas as clinician A, B, C, and D. So you can see basically the big green lines on the left represent right-sided colon adenomas of sub 1 centimetre, because the x-axis is the size of polyp in millimetres. So and then that's also demonstrated in a scatter plot where the sort of ratio in the different clinicians is compared, and you can see that the dots, the green dots for our the red dots for our clinician E are not as scattered as much, so they're not basically looking for those right-sided adenomas when they do it. So as a result, the outcome of that sort of NLP search meant that they were informed of where they were not performing as well as others, and then they changed their practice and then actually improved their polyp detection, which is important because we know in our specialty that the proportion of patients in whom you find at least one polyp directly correlates with your personal risk of missing a bowel cancer, which is basically what we all worry about when we do colonoscopy. So that was that's a really good use, and I think that using AI algorithms to sort of rapidly detect why KPIs are different between clinicians is is a great thing to be able to do, because these audits always take a long time. And then and there are sort of big clinical deals about this and getting this information out. So then moving on to AI using lesion detection. So I put a sort of slide up showing it on a still in action, where basically you've got a little polyp and a computer's put a box around it using image processing. Now, we published this graph about a decade ago from the endoscopy unit, and basically what it shows is that during a 4-hour list, an endoscopist will pick up more adenomas at the beginning of their list than they will at the end of it. And so, and the factors of this obviously are going to be fatigue and distractions and just being a human being, really. So that means that if you turn up to an endoscopy list in the first hour, you're more likely to have all the polyps you've got picked up and removed than if you turn up in the last hour. And so we do need things that are going to change that and change sort of, you know, human error and tiredness and all that sort of thing. So so essentially the sort of deep learning image recognition that we've got, sorry, I'll just go back one, can help be a second pair of eyes that, you know, doesn't ever get tired, is non-emotional, and just cracks on as long as it's turned on, and keeps on helping you detect things. Interestingly, we've had the opportunity to have these in the unit for a few months now, and try them. And one of the things I would say about any new technology is it's not without problems. Somebody said to me, I got very irritated as I realized I was snaring off normal bowel mucosa, or the boxes were very distracting and the specificity seems poor. And it's sort of like, well, why are you snaring off normal mucosa? Did you decide to leave all common sense at the door and not realize that the tool was it's a tool to help but not to tell you what to do? And so training in this stuff is an absolute essential element of when these technologies roll out, was really what I wanted to get across there. And actually the manufacturers say the same thing. It's a supporting tool and shouldn't only be used as the sole reliance. So how does it work? Well, so this is a sort of normal endoscope. You have the bowel, the scope, the video processor, and then you get a picture up. And then with the AI systems, essentially they put the CADE, stands for computer aided detection device. The CAD device goes in between the video processor and the monitor. It does rapid analytics on the image that's coming in, and then in real time puts boxes around the polyps. It's incredibly helpful, actually, and the algorithms are powerful, so there's a very minimal delay. And I've got a little demo video of it working here at Addenbrooke's. And you can see as the scope's just turned, there you go, it's gone hello, and there's the polyp there. And it works pretty, you know, it's pretty good. And the software for it's being sort of updated, you know, regularly. Does it work? Well, yeah, there is some data on that. So essentially, a meta-analysis published from uses around the world in 2019 and 2020 has shown that the AI generally seems to push up the adenoma detection rate against baseline, and that this meta-analysis favoured the use of AI above not using it at all, which is obviously good news. So the other, so that's in colonoscopy. The other area where artificial intelligence is going to be invaluable is in capsule endoscopy, which does a very similar thing to the tech I just showed you. And essentially the AI will will help detect abnormalities in the small intestine. So a capsule endoscope is a small device measuring about 18 millimeters in length and about 9 millimeters in width, with a couple of batteries in it, a wireless transmitter, some LED lights, and a small camera. It takes frames at a rate of about 2 to 6 per second, and the patient swallows it, and then you get a video of the small intestine given back to you on a data recorder that you upload to a specific bit of software. Over the time of recording, which is about 8.5 hours, it generates 40,000 images, and a clinician has to sit down and look at all those images in order to read it. And it takes, I mean, you sort of look at it as a video, and the capsule does stay still and you get the same picture repeatedly. But even with all that, it takes about 20 minutes to report each one, which when we do about 30, 40 a month here, it does add up to a significant amount of clinician time. So the AI basically will look at those 40,000 images and will delete from view everything that it's been trained to say is normal, and then show you only what's abnormal. So mass panic, of course, in the clinical world, because how can we allow a computer to delete things? Humans must be better, right? So so this is the first study published, and this was published at the end of 2019 in Gastroenterology. In China, they did a huge study using the Navicam Pro system, which we actually have in here at Addenbrooke's, where they looked at 5,000 patients who were duplicate read, conventional versus convolutional neural network based auxiliary reading. They did a discordancy analysis and then evaluated the results. What they found was remarkable. Basically, the blue bars is the AI, and the brownish gold bars bluish bars are humans, and the brownish gold bars are AI. And across the board, the artificial intelligence outperformed human beings in detection of pathology on the capsule endoscopes, reaching, not surprisingly for ulcers, because they're quite easy to spot, no significance for ulcers, but for things like polyps and mass lesions, like the things you really don't want to miss, because they're going to turn into malignancies, or already be malignancies. The AI really did win out. So this is tech that's here, and it's going to save substantial amount of clinician time and allow you to sort of supporting reporting, allow you to focus on generating the report, not worrying about how many you've still got left to read, and working to whatever time at night getting it all done. The other thing that is in the pipeline on capsule endoscopy, and my last comment is the capsule colonoscopy AI. And I think you probably, it did hit the mainstream news that you can now swallow a capsule and have a colonoscopy, which made me laugh because it made it sound like it was new, but we've been doing them here since 2014, and they've been available since about 2009. The problem with them is that anybody who's had a colonoscopy wouldn't have enjoyed the bowel preparation, I guess, but you have to drink 2 doses of that stuff to have a capsule colonoscopy, because you have to have one to clear yourself out and one then to clear the capsule through. But the problem with it is the colon capsules take a user 45 to 60 minutes to read. So until there's some sort of AI in there, the validity is not, in my view, not really there, but it might come. It might come. So these techs are definitely transforming what we can do and what we can offer patients. So my thought on AI is it hasn't come to take over yet, but AI in diagnostics is exciting. The evidence is growing that it's effective. I think lots of training on any users that are going to be having it is vitally important, so that people understand what the tools they're given do. And then I think in the next 3 to 5 years, most endoscopy units are going to have the sort of AI that I've shown you, and I have no doubt it's going to be rolling out in other specialties. So yeah, thank you very much for listening.
Gareth, thank you very much for a fascinating update. So there's a question in the chat from Mohammed Ahmed asking if whether the CAD device will end up getting rid of the problems that you described with clinician variation.
Yeah, it probably will, to be honest with you. But clinicians also, I mean, that's part of the training thing, is when do you introduce it? So do you, I mean, the capsule I've got, the capsule endoscopy thing I presented, that is a major issue, because if you, part of learning that thing is understanding how the small bowel works, watching the capsule go through, understanding where the pathology is and you know what it clinically means. In fact, just being shown the abnormal images doesn't give you the nuances of the whole system, and it certainly, for a trainee starting right at the beginning, won't be helpful. So you almost have to, you know, make sure that people can do the job properly, and then these tools are there to assist fully trained people in eliminating human error. And I think that's really important. They're there to assist, I think, fully trained independent practitioners to take away human factors more than being there to make it easier to reach the final point. And I think the whole of medicine needs to be really, really careful with that, with this sort of technology coming in.
That's an important point. Can I ask you a question about the stent from the beginning? So you said it's made of starch and it sort of dissolves. How does it dissolve in a chemical sense? Does it matter where it is? You know, does bile dissolve it at a different rate to other things?
No, I think I don't really so they're under patent, so they won't tell you how they work. But which is, we've had that with a few things that we use, like the hemostatic sprays were the contents of those were under lock and key when they came out 10 years ago. But my understanding is once it's exposed to the environment, it starts to degrade. So if they're in a sealed pack, and they actually have an expiry date that's very short for a medical device, only about 2 or 3 months, even in the sealed packet.
And is flow rate an issue?
It's flow rate.
Yeah.
No, it doesn't slow down at all.
So I'm obviously asking from a nephrological perspective, because after transplantation, we put in ureteric stents and then have to pull them out again, which is a nuisance. And I'm just wondering if they maintain the sort of flow rate.
Yeah, no, they were. The helical design is so clever. In fact, in metal stenting, there's some very similar shape designs that are coming in that increase the flow rate by double by putting notches and things into the stent. So these helical drain around the stent ideas work really well, and I suspect they'd be quite good for that.
I don't think any of our surgeons are here today, but I will point them in your direction, Gareth, to talk about.
Sure.
Has anyone else got any things they'd like to raise? One other thing, actually, I was going to ask, Gareth, was, I thought that the capacity for artificial intelligence to assess performance in the way that you showed us with physicians A to E is incredibly useful at detecting what would otherwise be undetectable variations in practice and fixing them. Do you have any strategies that you think are really important to build that into the process of training and practicing in a non-accusative, positive way, rather? Because you could imagine it would end up with an internal ranking system that could cause tension otherwise.
Absolutely. So we've been doing it in endoscopy for years here. So what everybody has to have their KPIs assessed on an annual basis, and because we have a nice suite of metrics that you can look at to determine that you're providing a quality service, we got the whole department to agree to put names to KPIs in our regular audits, and it sort of just getting everybody engaged in the process, and then having a supportive environment for what can we do to help should your performance be a bit lower this year, and we've actually done that as well, where one clinician had a very low polyp detection rate for a very good reason, due to the patient types that were coming to them, and then we introduce make sure they get more of a mix of cases coming to their list as a result, or just accept that their practice will involve lower KPIs and it's not an issue. So you can definitely do that, but it needs the team to engage, good leadership, and making it very clear that it's about maintaining quality as a team and not about, like you say, being accusatory.
Okay, Gareth, that's terrific. So thank you very much. Amelia, thank you as well for your presentation. Terrific meeting today, and I look forward to seeing everybody virtually next week. Thanks very much.
Thank you.